या डॉक्टर राहुल, या गुड इवनिंग सर, एक बार ऑडियो वीडियो चेक कर लेते हैं सर।
हाँ जी,
यस,
हाँ
हाँ सर,
हाँ,
नमस्कार। कैसे
नमस्कार
हैं?
नमस्कार। ठीक ठीक है।
चलिए, ग्रेट ग्रेट सर, नाइस टू सी यू,
हाँ,
वेलकम सर।
ठीक।
Yeah, your audio video is absolutely very clear, sir. Not
हाँ,
an issue. We'll start at 7:45. We are waiting
हाँ
for
जी,
Dr. Rakhi Sagarwal and Dr. Manikant ji.
हाँ
And
जी,
Dr. Saurav ji already log in कर गए हैं सर।
ठीक।
कोई दिक्कत नहीं, ठीक ठीक ठीक, राइट सर।
Hello.
Doctor साहब, yes, good evening, sir.
Good evening. Good evening. तो अब क्या करना है इसके बाद?
सर आपका ऑडियो है क्लियर, एक बार वीडियो ऑन करना है सर आप.
वीडियो कहाँ से ऑन होगा? ऊपर से स्पीकर भी होगा.
लेफ्ट बॉटम में लेफ्ट साइड में देखेंगे सर.
Right.
यस यस यस.
Okay now?
हाँ यस सर. तो प्रोग्राम का ऐसा फ्लो रहेगा सर. अभी ऑडियंस के लिए अभी ऑफ है ये. अभी हमने ऑडियंस के लिए ऑन नहीं करा. और अभी ऑलरेडी डॉक्टर सौरभ अरोड़ा, डॉक्टर राहुल कटियाल लॉग इन कर गए हैं. हम डॉक्टर मणिकांत जी का वेट कर रहे हैं जो लुधियाना से है. तो प्रोग्राम में मैं ओपन करूंगा और सबको इंट्रोड्यूस करूंगा एज स्पीकर्स का. और उसके बाद देन आई विल हैंड ओवर टू यू और देन वी विल हैव डिस्कशन ऑन दोस पॉइंट्स सर जो आपको शेयर करें हमने.
Right.
और आफ्टर दैट आई विल टेक देन 3-4 स्लाइड्स हैं, कुछ ऐसी ब्रांड से रिलेटेड भी हैं, कुछ यूनिक इंपॉर्टेंट इन्फॉर्मेशन है, वो शेयर करके वोट ऑफ थैंक्स देके क्लोज करेंगे सर.
Right.
मतलब स्लाइड प्रेजेंटेशन नहीं है, मतलब जस्ट डिस्कशन है बेसिकली.
हाँ, that I understand.
Yes, we have Dr. Manikant also logged in, sir.
Right.
So all have come.
Hello,
Dr. Saab. Good evening.
hello, हाँ, good evening. क्या हाल है?
बस all well, sir. I'm Rakhi Sagarwal. We have already, sir, all have logged in.
Okay.
तो डॉक्टर साहब की परमिशन हो तो मैं स्टार्ट करूंगा सर.
मैं ना अभी 5 मिनट में रीलॉग इन करता हूँ. अगर अभी तो पार्टिसिपेंट्स आ गए हैं तो बाकी.
हाँ सर, सब आ गए हैं सर. ऑल हैव कम.
जस्ट 5 मिनट्स में मैं करूँ दोबारा.
हाँ कोई नहीं, अगर इनकेस अगर हम स्टार्ट कर देंगे तो यू कैन लॉग इन बिटवीन सर. मैं तब तक इंट्रोडक्शन और वो चीज स्टार्ट करूंगा.
हाँ सर, आप स्टार्ट कर लो, मैं 5 मिनट्स में करता हूँ.
ठीक है सर. Shweta, can we ask to make it live now for audience?
Yeah, sure.
Yeah.
We are live.
Live. So just with your permission, sir, I am just opening the program, sir. So on behalf of Welcome Laboratories, India's 5th largest pharmaceutical company, I, Rakhi Sagarwal, welcome our eminent doctors, those who have joined us for today's panel discussion titled Views on Vildagliptin. At Elchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us navigate through the meeting, we have with us today Dr. Rakhi Sagarwal, who will be our moderator for today's panel discussion. And I take this opportunity to welcome him, sir, for this program.
Thank you.
Thank you very much, sir. And Dr. Rakhi Sagarwal, Assistant Professor, Government Medical College, Amritsar, has more than 25 years of experience in the field of medicine and has many publications in various journals, nationally, internationally. I welcome you, sir, for this program, sir. Thank you very much.
Thank you, Rakesh.
Yeah, at the same time, also, I would like to introduce panelists, sir, and those would be, in today's program. We have Dr. Manikant Singla. He is an eminent endocrinologist with outstanding record and high academic interest. He has more than 15 years of experience and is presently running his own center, MK Sendo Consult, Super Specialty, Diabetes, Thyroid, Obesity and Endocrine Center, Ludhiana. He has given his service as a consultant in DMC and H for 9 years and has contributed in various national and international clinical trials, especially related to type 1 and type 2 diabetes, and has attended various national, international conferences and courses related to endocrinology and diabetes. Active member of American Association of Clinical Endocrinology. Thank you very much, sir, for giving your time. Welcome to you for this program, sir. And then we have Dr. Saurabh Arora, Assistant Professor in Department of Endocrinology, Danan Medical College and Hospital, Ludhiana. He has 8 publications in both national and international index journals, presented papers at both national and international conferences, and early detection, like one of the paper is early detection of lipohypertrophy in insulin injecting patient with diabetes mellitus in ADA 2020. And he is investigator in 4 clinical trials as well. An area of interest is primary hyperparathyroidism, obesity, and local complications of insulin therapy. These are his areas of interest. So welcome, sir, for this panel discussion on vildagliptin. Thank you very much. We have with us on board, sir, Dr. Rahul Katial, Consultant Pulmonary Medicine and Non-Invasive Cardiology, ACE Heart and Vascular Institutes, Shivalik Hospital, Mohali. He has scientific publication in various journals and has membership of various scientific national and international bodies. So welcome you, sir, for this program, sir. So not taking much time, I would like to hand over now the session to Dr. Rakhi Sagarwal to set the context and start the panel discussion. Over to you, sir. Thank you very much.
Thank you, Rakesh ji. Should we start? Dr. Manikant has joined.
Yeah, he will be joining in another 3-4 minutes
I
time.
think,
Till the time we can start with. Yes.
Okay, thank you. Good evening, friends. So I welcome you all on this discussion on DPP-4 inhibitor vildagliptin. I feel privileged to be part of this meeting as moderator amongst esteemed and learned panelists. Sir, as we all know that about a decade back, diabetes was being treated with only few drugs like insulins, metformin, and secretagogues like sulfonylureas. Lately, now we have got many strategies to treat diabetes, and amongst those, one of these is DPP-4 inhibitors. And among these DPP-4 inhibitors, vildagliptin is one of the important DPP-4 inhibitors being used, and recently its cost has come down. So we'll be mainly focusing on vildagliptin DPP-4 inhibitor. As per protocol, we have got discussion points, clinical discussion points. Rakeshji, my first point is we have Dr. Manikant. Should we start or we should start from the second point?
Yeah. Anybody can share his views, sir. You can start with anybody, not issues.
Okay. So I'll put that question to Dr. Saurabh.
Yes.
Dr. Saurabh, we know that diabetes mellitus type 2, when diagnosed, we should start early treatment. And we know that whether we should use combined therapy or monotherapy, this is a dispute. And with vildagliptin, verified trial has been done lately. And we have got results from that trial. Keeping into that trial into background, what do you think? What is the optimal strategy to start a combined therapy or a monotherapy with vildagliptin?
Vildagliptin, sir. Actually, you're absolutely right with the data of verified trial, which has shown that the combined therapy with vildagliptin and metformin, if we compare it with those patients who are taking metformin alone, A1C control was better, and the durability, especially the second point, durability of the response, it was better in the combination arm. So in our practice, we also see that patients who have it, first of all, it depends upon HbA1c level. If the A1C level of a patient is around 8.5, in our practice, we have seen commonly that these patients do not achieve target with monotherapy. Especially there is data. There are some papers to show that if A1C is around 8.5 or more, probably we should go with the combination therapy, because chances of failure of monotherapy is quite high in these group of patients. And if we use monotherapy, the durability of response is more, and there are more chances that we will achieve our target, whether it is A1C target of 7 or 6.5, depending upon an individual. It's better to use a combination therapy. And suppose if a patient comes to me with an A1C of 7 or 7.5, 7.1, 7.2, but I want to use in those group of patients, definitely we can try with the metformin monotherapy. Will get a response. First factor is the A1C level, which we are dealing with, and second is durability of response. Durability is more with the combination therapy as compared to the monotherapy, but definitely we have to take into totality. We have to see a patient, and we have to take various factors into account while starting a patient on monotherapy or combined therapy. But for me, if patient is having A1C of more than 8 or 8, I'll go with the combination therapy. The response is quite good.
Quite rightly, you have said that durability is more important. And I think secondary treatment failure is less with the combined therapy compared to the monotherapy.
Yes.
Anything more you can add on this verified trial?
So that was the one regarding the durability, and another A1C achieved. The target A1C achieved was significantly more in those patients who used combination therapy as compared to the monotherapy.
So point taken. Next, we come to the second discussion point. And I think that I can, Dr. Manikant is still not there. So we can go for that second point. We can discuss with you and Dr. Katyal. Sir, we know that these days we are giving different drugs. Patients are either on the sulfonylureas or on the SGLT inhibitors or on the insulin. Then what is the scope of adding vildagliptin to these patients as a combined therapy? Suppose one patient is taking, we'll take one by one. Suppose one patient is taking sulfonylureas and we want to add vildagliptin. What is the scope of this combined therapy? Dr. Rahul? Sir, you are not.
Yeah, Dr. Rahul,
Hello.
unmute yourself, please.
Yes, you are. No,
Okay,
you
sir.
are.
Sorry. Sir, vildagliptin significantly improved glycemic control in patients with diabetes inadequately controlled with metformin and sulfonylureas combination. The addition was well tolerated with low risk of hypoglycemia and weight gain. So there was also a
Yes.
study, Edge study was done,
Edge study, right.
in which vildagliptin in combination with other oral hypoglycemic agents show better clinical benefit, that is HbA1 reduction, better control on hypoglycemia, and there was no weight gain in the patients combined in combination therapy.
Right, sir, right. Definitely, because these gliptins, they are weight neutral and there is a weight gain with sulfonylureas. So if we add, there is no additional weight gain. Rather, there is a better control when we combine these two. Dr. Saurabh, what if we add, patient is already taking sulfonylurea plus metformin, still we want to add vildagliptin?
Yes, definitely, sir. If the patient is already taking sulfonylurea and metformin, and patient is not adequately controlled on the combination of sulfonylurea and metformin, I think addition of a gliptin is another good option in many ways, because if we go on to increase the dose of sulfonylurea, we are doing it at the risk of additional weight gain and at the risk of hypoglycemia episodes. Rather, it is better to add another agent which does not cause hypoglycemia and weight gain and has a different mechanism of action as compared to the sulfonylurea. Both are no doubt results in increased insulin secretion, but the mechanism is different. So that we are going to get a good results. And as we know, sulfonylurea going up to 4 mg, we get an response, very good response. But above 4 mg, the A1C reduction is very less. If you increase the dose of glimepiride above 4 mg, we are not going to get much out of that if the patient has not responded to 4 mg. And for these kind of patients, definitely add-on therapy with vildagliptin will definitely help. And in other group of patients, if suppose a patient is taking around 2 milligram of sulfonylurea per day and not adequately controlled, in that patients, probably I would like to keep that patient on 2 milligram of glimepiride only and would like to add metformin, vildagliptin, so as to reduce the risk of hypoglycemia and have a better glycemic control. Even in those patients who are taking insulin therapy, we have seen that addition of gliptins and metformin to those patients who are not very well controlled on insulin therapy, there we see a good control when we add a gliptin and a metformin, because the action is different. What does vildagliptin does? Vildagliptin results in increase in portal insulin. So even a small amount of portal insulin will act on the hepatic gluconeogenesis pathway, and it's going to give a good control. So even in sulfonylureas as well as in patients who are taking insulin but are not adequately controlled, we have always used metformin to control blood glucose level in these group of patients. But addition of, I think, gliptins also is another option that we can avail in these group of patients.
So you have already answered my next point. I was going to ask about the insulin with the gliptins. You have already answered that. That's good. And rightly you have said that gliptins, they act by a different mechanism than sulfonylureas. They don't cause hypoglycemia because they secrete insulin by that is glucose dependent release of insulin. So we have now Dr. Manikant also. Welcome, sir. Hello.
I think, sir, he is logged out again because of technical. He would be joining, sir. Yes, he has joined, I think. Yes.
Should Hello.
Okay. Hello.
Sir, are you there, Dr. Manikant?
Yeah, I am there. Am I audible?
Yes, you are audible, but your video is not visible.
Okay, just a second. Okay. Yeah.
Welcome, sir.
Yeah.
So
Good evening, everyone.
we were discussing about vildagliptins as an additional therapy to traditional drugs like sulfonylureas. We discussed with sulfonylureas. We discussed with the insulin. So now these days we have got another important oral anti-diabetic agents in the form of SGLT2 inhibitors. These glyphazones, AMPA, CAMPA, all these. So what do you think? Can we add vildagliptin as a additional as a add-on therapy to these patients who are on SGLT2 inhibitors?
So definitely, as Dr. Saurabh already discussed, that first you start either metformin is first drug. After that, you can add either DPP-4 inhibitor or SGLT2 inhibitor. Suppose patient is already on SGLT2 inhibitor plus metformin. So what happens when you give SGLT2 inhibitor? There is an increase in endogenous glucose production. So glucagon level is increased. So that leads to increase in endogenous glucose production. But when you add DP4 inhibitors, they inhibit the glucagon. So which in turn leads to suppression of glucagon and suppression of endogenous glucose production. So that is benefit of adding the DP4 inhibitor. So and second thing is when patient is on metformin and SGLT2 inhibitor, so there is no hypoglycemia, and also when you add this DP4 inhibitor, there won't be any hypoglycemia also. So this combination is synergistic scientifically also because it helps in glucagon counter regulation both the ways. If glucagon is increased by SGLT2 inhibitor, that is counteracted by the DP4 inhibitor. So that is why this becomes one of the best choice because patient won't gain any weight. There is no chance of hypoglycemia, very, very less chance of hypoglycemia, and A1C will be reduced. So I think this is one of the good scientific combination which we can definitely add, and this helps a lot to the patient.
Rightly, sir. There is some weight loss with the SGLT2 inhibitors, but this is weight neutral, these gliptins.
Yeah.
So rightly you have said endogenous glucose production is countered by each other. Rightly said, rightly. Thank you, sir. Then we come to the another clinical discussion point. Sir, diabetes and nephropathy, we know they go hand in hand almost after a few years. And we have quite a number of patients who are diabetic and they have got nephropathy. They have got impaired EGFR. Sir, what do you think? What is the scope of vildagliptin in such patients?
Okay, this question has been addressed to whom?
Sir, to you, sir.
Okay. Right. So in nephropathy, as we know that in nephropathy, choice of oral drugs is limited. Like sulfonylureas, only like glimepiride or glipizide, sometimes we add. So which can cause hypoglycemia, weight gain. And hypoglycemia is a major concern in CKD patients. Metformin also in end-stage renal disease or GFR less than 30, we tend to avoid. But these DP4 or SGLT2 inhibitors, they are becoming very good choice in CKD patients as well as has been seen in the DAPA CKD trial also up to GFR of 20 also these drugs were used. And in fact, they helped in the progression of albuminuria, they helped in progression of CKD and all those things. But SGLT2 inhibitor still, like if a diabetic patient with kidney disease is cachexic, so sometimes it becomes difficult to use. But if you see the side effect profile, DP4 inhibitor are the drugs which have the least side effects. And when you use these drugs in CKD, so the patient won't have any problem in terms of side effects and in terms of weight, in terms of heart failure as well. And in CKD also, they are neutral. And on the vildagliptin, there are many studies which have been done in elderly patient as well, more than 70 years, more than 75 years. So they have done the studies on CKD patients, and it has been found that they decrease the A1C, and they also help in the retardation, a slight retardation of CKD as well, and they don't cause any hypoglycemias. And one thing about this vildagliptin is you have to adjust the dose according to the GFR. Means if you are giving twice daily in moderate to severe renal impairment, you can use it once daily. So 50 mg once daily can be used. So that becomes the dose. So you have to modify the dose of vildagliptin in such patients. Otherwise, these are very good drugs to be used in a patient of type 2 diabetes with CKD.
Sir, after which eGFR you will not like to use gliptins?
Gliptins can be used at any EGFR, means it
Even
can
in
be
the
used at any
below
GFR.
15? Below 15 also, sir?
Normally we if you see that linagliptin, etc. So average gliptin can be used even at GFR of less than 15.
But
Only thing is you have to reduce the dose. Also in dialysis patient or end-stage renal disease, many times you have to use insulin. But if patient is having very mild hyperglycemia, so these drugs work sometimes, even in patients who are on hemodialysis or end-stage renal disease. So these can be used, just you have to modify the dose of the gliptins.
Thank you, sir. Thank you. So now we come to the next discussion point, which is the use of gliptins or vildagliptin in elderly population who are having various cardiovascular diseases along with that. This is discussion point is for Dr. Saurabh and Dr. Rahul Katyal. Sir, what are your views regarding use of vildagliptin in elderly population who are having various comorbid conditions, cardiovascular conditions?
Sir, in elderly patients, the vildagliptin is quite a safe drug to use in elderly patients. Various studies have shown that gliptins as a group do not carry additional risk of hypoglycemia, actually, because these elderly patients are because of erratic food intake and other factors, decline in EGFR, due to multiple factors, these patients had higher risk of hypoglycemia as compared to the young population. And gliptins as a drug do not cause hypoglycemia. And additionally, elderly population, some of the patients might be having underlying cardiovascular disease also, and hypoglycemia can be detrimental for those group of patients. So vildagliptin is quite a safe drug to use in elderly population, especially in patients with cardiovascular disease. It's also quite safe. It does not cause QTc prolongation as compared to the teneligliptin, and it can be safely used in patients with cardiovascular disease also. There was some concern regarding the increased LV diastolic volume in VIVID trial, but further studies are needed on to look on this parameter, and none other studies have shown any detrimental effect on the cardiovascular health as far as vildagliptin is concerned.
Dr. Rahul, your views on cardiovascular safety of these gliptins, especially vildagliptin?
In my patients, hypoglycemia was major concern, which has decreased with the use of vildagliptins in elderly patients. So hypoglycemia was major issue in my patients, but it has improved.
Dr. Singla?
Yeah, as Dr. Saurabh rightly pointed out, in VIVID trial, there was some concern, but after that, a lot of meta-analyses have been done on vildagliptin, so in which it was found to be almost CV neutral, you can say. So there was no increase in the CV mortality or like that. So that was a very large meta-analysis in which it was shown that it is safe even in cardiac patients.
But no benefits like acetylcholine inhibitors.
Yes.
Definitely. So, because with the DP4 inhibitor, no DP4 inhibitor was found to be beneficial. It is only neutral, you can say. This does not do cause any harm. So it is a good thing that they do not cause any harm. But if you talk about benefits, so that was not there with any of the gliptins. So these are just you can say cardiovascular neutral drugs.
So in between, one thing has come to my mind that these days we are having many COVID patients. They are having stress hyperglycemia due to the disease. They are on the steroids. They are already diabetics. What do you think? What is the scope of these vildagliptins in these types of patients, in addition to insulin, which we are using?
Okay. Like if you see about the DP4 inhibitors, so there were initially there were few controversial studies regarding DP4 inhibitors, whether we should use it or not, because DP4 was found to be a entry point for SARS-CoV-2. But ultimately, when a lot of studies were done, it was found to be safe. So sitagliptin, or there were more studies with sitagliptin.
Yes.
But with vildagliptin, one thing is like, or with any other gliptin, so you have to look at the LFT also. If that is more than 3 times normal, so preferably these drugs should be avoided. Otherwise, if patient's liver profile is okay, in mild or moderate disease, definitely we can use these drugs. If patient is hospitalized, requiring high dose steroids, etc. So I think insulin is the best drug which can be used in such patients.
Dr. Saurabh, your views?
Yes, sir. Definitely, as sir already said, Dr. Manikant already said that in majority of the patients, we will need insulin to control the blood glucose levels post-COVID status, especially those who are on high post-COVID steroid patients. But definitely, vildagliptin is useful, especially a combination of vildagliptin and metformin can be used if the patient is having normal liver and kidney functions to lower down the dose of insulin. Patients on very high dose insulin, those who are requiring very high dose of insulin. So there is, if we cut down the dose of insulin with the use of OHA slightly, probably the risk of hypoglycemia also goes down with that. So that's because in many patients, COVID-19 who are
This can be safely used in COVID.
Yes, it can be safely used if liver functions are normal.
If liver functions are normal, but they are likely to be drained in these types of patients.
Not in majority of patients. Majority of patients with mild to moderate category of disease, we will have transient elevation of OTPTs, which are controlled when the patient is discharged. OTPTs are normal in many patients. At the time of admission, we have abnormalities in OTPTs, but in many patients, OTPT normalize at the time of discharge, and you can add gliptins.
And especially in OPDs, like we are seeing that most of the COVID patients, LFT is not means high. Mild patient, their LFT is normal most of the times.
Yes, we have seen RFTs being drained more than LFTs, definitely. So then again, a last question. This is for all the panelists. This is a discussion point. We know that this vildagliptin has lately gone off patent. Many pharmaceutical companies have come with this brand now. There is a, what you say, around about 200 brands, I suppose, like something like that.
Maybe more than that.
More than that. What do you think? What is the scope of this molecule now? It has become cost effective. Will it continue? Will this molecule sustain in the market? With its benefits?
Yeah.
What do you think?
Okay. Should I answer?
Yes. This is open to everybody.
So,
this is a commercial question, but we still.
Actually, what happens when the cost of a drug becomes very low? So, like vildagliptin is now very cheap, so it has replaced means after metformin. Like because of cost, sometimes we used to give sulfonylureas or teneligliptin like that. or Paglitazone. But after this cheap combination means cheap vildagliptin, I think usage of sulfonylurea initially has gone down, and chances of hypoglycemia, weight gain, and monitoring cost also becomes down. When you don't have to monitor the blood glucose, indirectly you are saving the money. And second thing is, uh, like teneligliptin, previously it was used quite often in most of the patients because sitagliptin, linagliptin were very costly. So teneligliptin was used more frequently. But when this vildagliptin has become cheap, I think prescription of teneligliptin has gone quite down just because it does not have any cardiovascular safety data, you can say, or there was some concern about increased QT interval, etc. Although means does not have that much of scientific data on cardiovascular safety. So I think usage of teneligliptin has gone quite down, and vildagliptin has increased. And now they have launched OD drug also 100 mg OD. So previously 50 mg twice daily was slight issue because of the compliance. So I think with the OD drug 100 mg OD, compliance will improve and usage will improve. So I think this drug is going to sustain because cost has become very less. So what is your view, Dr. Saurav and Dr. Rahul?
Dr. Rahul?
Dr. Rahul, you are not audible. Please unmute yourself.
Sir, usage of vildagliptin has increased after rate reduction. First preference, first line treatment is metformin. Then we use glimepiride, but now vildagliptin and metformin combination is directly used as the first line, and it has provided affordable, cost-effective treatment to patients also. Price has reduced around one third, more than one third.
I think they have come in combination with metformin also.
Yes, sir.
Yes, combination. So we are using vildagliptin and metformin combination.
We have 50 milligram, and we have got combination with metformin also.
Yes.
So, thank you, gentlemen. We had a very fruitful discussion on vildagliptin. Mr. Upadhyay, any questions for panelists?
Yeah, sir. In fact, questions will come, but we have not given this. We are not taking questions in the platform as such. If in case some other questions comes up, we will approach to you and out of the registry, sir.
Thank you very much, sir. So now I hand over the next proceedings to Mr. Upadhyay.
Yeah, thank you, sir. I will, in the same context, sir, I will take you through one very important information regarding vildagliptin, and then there is another one platform which is nowadays being used because of current pandemic situation. So please allow me to take another 2-3 minutes, sir, so that I just go through it. Yeah, thank you. Yeah. I think the slide is visible, sir.
Yes.
Yeah, thank you. We have, sir, I would just like to just bring into your notice, sir, the first time in the world, once daily vildagliptin from Alchem in the management of diabetes, as just what you have been sharing, sir, we have Glovilda OD 100 milligram sustained release for good control in diabetes. 2 points I wanted to highlight here, sir, in this slide. One is bicovalent to the innovator brand, which was given 50 mg BID. First. Second is 84% DPP4 inhibition over 24 hours with vildagliptin sustained release at par with the innovator brand 50 mg. So we have some trials with us, some data with us provided to you in when we will meet you, sir, in person. So these are 2 points I wanted to highlight. And now, other than vildagliptin, I will just take you through one virtual platform, which is online consultation. This is Connect to Clinic, absolutely from Alchem, sir. This is free for any doctor can use it. So this is teleconsultation. Unique features of Connect to Clinic is, sir, credential-based allows doctors to create their password to log in platform, and this will eliminate dependency on OTP. So once a password is created, then there is no need to put OTP every time you do consultation. Then patient bulk upload feature is there. Doctor can upload the patient details in C2C platform. My patient tab is the one tab in that option in CSV format. So, and he can view the details of the patient. Prescription share via email and SMS. Platform now allows to share the prescription over mail and SMS so that patient can access it outside the platform as well. The shared prescription is password protected, like just putting a mobile number patient will put to ensure authorized access. And provision of adding of alternate number by doctor. This is another feature. Doctor can add alternate additional number which can be displayed in the prescription. Doctor has option to select the number which can be displayed so that he does not get bothered by the repeated calls of from the patient. So this is a specific number he can add upon, sir. Instant consultation is new feature which is added. So doctor can initiate instant consultation with patient without the need of booking the time slot. Three-way AV consultation. Patient caregiver can share the consultation link to the patient. Now caregiver and patient can join the consultation with the doctor. There is medicine update, C2C med update, wherein international journals, full text articles at no extra cost for any doctor. And there is patient education module related to your field, sir. You can share with the patient, like diabetes or cardiac related, some patient awareness, knowledge you want to share, you can share with this platform, sir. And then role creation option for staff to make edit booking other than prescription. Your attendant, your staff, your helping hand can help this, booking the slots. So it will save your time as well. And physical consultation can also happen in C2C. So this is about this connect to clinic, sir. And this is a very specific feature which we have started. Now, not taking much time, sir, I would like to just thank you, all of you, sir. And this is opportunity to take to thank Dr. Rakhi Sagarwal for moderating the panel discussion. And I also express my sincere thanks to all the panelists for sharing their views on vildagliptin in a clinical practice. And we'd also like to thank all the doctors, those who have joined us for panel discussion. And I'm sure you will appreciate the views on vildagliptin presented today. We salute our doctors, paramedics who have contributed immensely for keeping us all safe and healthy in these challenging times. And we at Elchem will continue to serve doctor and patient by making a product available like Bluevilda M, Jupirose, and Olchem. So thank you, sir. Thank you very much for coming to this program, sir. Thank you, Doctor.
Thank you, Dr. Singla. Thank you, Dr. Saurabh. Thank you, Dr. Patel.
Thank you.
Thank you. Thank you, sir.
Thank you very much. Thank you very much. Thank you. Yeah, there is an option, sir. Leave का होगा, sir, Doctor साहब. Right side में देखेंगे bottom में ना. There is an option of leave. Yeah. ठीक है, sir. फिर मिलते हैं, sir.
Okay.
Okay, sir.